Hi, I'm Dr. Faranak Kamangar. I am joined by Dr. April Armstrong. We're at the SF Derm Eczema Symposium and 100-year celebration. It's a very momentous occasion. I'm so happy to have Dr. Armstrong here, and I'm going to go over your very impressive bio briefly before we start chatting. But Dr. April Armstrong is a professor and chief of dermatology at the University of California, Los Angeles. She is a renowned expert in inflammatory skin diseases, including atopic dermatitis and psoriasis. Dr. Armstrong is also a recipient of the Lifetime Achievement Award by the National Psoriasis Foundation. She's conducted over 150 clinical trials and has published more than 400 peer-reviewed articles in dermatology. And I have to say, she's been a forever mentor to me as well. So thank you so much for joining. This is so exciting to have you here.
Yeah.
And mainly, we really would love to, since you're the expert on psoriasis, we just love to get some ideas for you as what's going on with psoriasis therapies right now and future of it. So what would you say about current state of psoriasis therapies, or any comments?
Yeah, first of all, thank you for having me here, Dr. Kamangar. I think, first of all, you've done a terrific job putting together this meeting, and I'm very honored to be a part of the meeting. When we think about psoriasis therapies these days, I think there are about 4 different trends that are happening with regards to patient care and research. And first is really precision medicine. How do we determine which patients may respond to a certain type of biologic versus another, so that it will not be a guessing game? For example, when we start a patient on one of the IL-17s, is this patient going to be a responder versus maybe this patient will never be a responder? And there are a few different efforts ongoing with regards to non-invasive methods of collecting, for example, patients' RNA from their skin scrapings. When I was at USC, we were involved in some of these studies looking at how these RNAs can be tested against the different biomarkers, and looking at then what the results may show, telling us whether the patient is in responder to, for example, IL-17 inhibitors versus IL-23 inhibitors, or neither, such that the patient can be started hopefully on a more precise medicine to their particular genetic makeup. So I think that is probably something that's coming.
That's going to be amazing. I think it's going to be so great for getting things approved too, isn't it? It's just like, well, we have to use this medicine because this would be the precise medicine that would work for you.
Absolutely. And I think it's an approach that's very sensical. We've seen it in oncology. So I think applying that to derm would be helpful. The other trend is E, which is early treatment. So there's really a push with regards to how can we get our patients into our clinics earlier, such that they can be treated earlier. And there's studies showing that early treatment can potentially modify the disease progression in the future. And in studies that are being conducted currently, some preliminary data show it may even prevent, for example, psoriatic arthritis in patients who started on, for example, biologics or oral systemic therapies early. So treating patients early, I think, is always something that's very helpful.
That's so exciting, because we have our model diseases like pemphigus vulgaris, where we sort of had that mindset of let's catch it early, just hit it very hard with, let's say, Rituxan, and it might modify the disease. So yes, that thought's very exciting. I don't know if we have enough data quite yet, but do you think that would be a possibility for some of these inflammatory diseases where you would just see them earlier? And also, I would guess, is it mostly kind of using higher doses of medication too? Because I think of Rituxan like kind of heavy duty.
Right.
Going in there with bigger guns.
I know there are investigator-initiated studies looking at using higher doses of biologics early on to try to get people into almost a remission state. We don't know yet what frequency they may need some of the biologics later on. But certainly some of the early data have shown pretty promising
amazing.
Going early and going hard may actually change a person's predisposition later on, for example, for their disease progression.
That's amazing. Amazing work.
So, and then the fourth trend is really looking at treatment of milder disease with systemic medication. So we know for a very long time, we sort of have our biologics and oral therapies for a very long time for moderate to severe disease. And then we had, for example, Premalas that's approved for all severities for patients who are appropriate for systemic therapy. So we're seeing now really a progression of potentially looking at the possibility of using biologics for milder disease if there's a rationale. So for example, since the safety profile is well understood for many of these medications, and especially for limited disease where topicals could still fail if that can be used. So that's one sort of research trend that's happening.
And special sites, right? If they have to have it very severe, but on the scalp alone, in theory,
Absolutely.
we consider that mild, but they could be it could affect the quality of life, could impact social interaction.
Yeah.
So I love the other research protocols that are being done around the quality of life and everything else that goes into it, rather than just the BSA and how we kind of categorize
Absolutely.
the different fields. I'd be curious to kind of combining those two trends. If we do find data that if you hit it hard, you can kind of modulate it, would you do that with all psoriasis or would it be like the more severe presentations that you would do that with? So it'd be interesting to see how these things kind of pan out.
Absolutely. Yeah. So I think with these veins of research, I think we should be kind of moving in the direction of really how we can elevate patient care above and beyond what we have already, which we are very lucky, as you know, and I know that Dr. Kamangar, that you've done a fellowship as well in psoriasis, so you're very well versed in the area and also have contributed greatly to that area. So I think we're actually very lucky where we are, but it's about how we can even elevate that degree of care. And there are a few sort of innovations that are more therapy specific. So for example, when we think about topical therapies, a lot of the energy these days, as we know, are spent into looking at non-steroidal topicals.
Right.
And we have, wonderful options that were approved within the last 2 years, looking at different pathways with tapinarof and topical roflumilast, which has shown efficacy, I would say probably much greater than what we've seen in the past with the non-steroidals in this area. So I think that has already benefited a lot of patients. There are medications in the pipeline, topicals, that may be looking at topical TYK2 inhibitors.
That's really exciting.
Yeah, it could be helpful.
No, that's really great, because I think for years patients have been kind of telling us they don't want to use steroids.
That's right. Yes.
We know if you use steroids safely, it's fine to do, but I think that trend has been there. So it's so great to actually have these options, because in the past it was, well, use the stronger steroid because it'll work, or I guess sure, use the non-steroid, but it's going to take forever.
Right.
So it's actually really great to have that option. It does fill a very specific niche.
Yeah.
And then what do you think about, there's really interesting, the mechanisms of action of these new topicals and the sustained clearance. I think that's really interesting, because we kind of thought that with some different modalities, but with topicals, you usually kind of have that mindset of, well, you use it, and then when you stop it, it kind of comes right back. And that's kind of the mindset patients have. When you educate them now, do you mention that to them now that, well, like with this therapy, you may, after stopping, and it doesn't happen with everybody, but that kind of sustained clearance of the maintenance phase without use?
Yeah, I think that's a great point. We're seeing data that the maintenance of clearance is maintained beyond what we might think, and it's very interesting, because I still probably advocate for proactive therapy, that once it's clear, that they could still use a medication twice a week on the frequently recurring areas to decrease flares. But we know in the real world, I don't know how many patients are actually following that, because if they don't see it, they'll just they're not incentivized to put the medication on. And I think in the real world, what we're observing is that in those cases, very real world application of the medication, these newer topicals, that we are seeing a bit longer. Yeah. We can call it, we call it remittive effect than the prior topical. So I think that's very exciting as well. Yeah. And I would say for the oral realm, most of the small molecule development for the oral realm has been centered around TYK2. I think we've, as a field, kind of really have honed in on TYK2 as a target. We have deucravacitinib that's already approved. There are 2 other medications that are in the pipeline that are also targeting the same target, TYK2, that's in late phase development. So I think we've we've really, I think in that realm as a field, we've struggled a little bit to figure out what is the right target.
Yeah.
But I would say looking at the pipeline, I think the field for small molecules, that TYK2 seems to be the right target. And then now the conversation is really going to how specific it is for the regulatory domain of TYK2 versus, the existing TYK2 inhibitor. And another very exciting area in the oral therapy development is these peptides that act like biologics. I call them biologics, but they are actually oral medications that are made of peptides, and you take them as orally, and they would inhibit, for example, IL-23 receptor, right?
Wow.
So it's kind of like a very, you would think of a molecule that does that would be a biologic, but they've been able to engineer it as a peptide. And we also have another peptide that inhibits IL-17, for example. So really almost injectables in the pill.
That's amazing.
Yeah.
So it's not degraded. They bioengineered it down to the molecular level. Very exciting.
So that's very exciting.
I think that the biologics have revolutionized dermatology. And now if you kind of look over like the last 100 years, we're talking about it's a short amount of time we've had the biologics. And every year, newer and newer therapies are coming out.
Yeah.
So I think we're lucky. It's a good time
We are
to be a dermatologist
Absolutely.
in the inflammatory disease field.
Absolutely. And I think that the biologics, to your point, we're probably going to look at the launch of IL-17 A and F dual inhibitor bimekizumab in the near future. It's already approved in other parts of the world, but I think we're going to see that coming as well.
Soon.
Yes, yeah. So it is very exciing in psoriasis and also in atopic dermatitis, which is a whole different area
it's kind of following,
as well.
It's following behind.
Yes.
But then I feel like it's going to really effective medicines really quickly.
That's right.
Whereas psoriasis kind of like had this slower start, and they're just atopic derm is just going straight to just getting clear skin.
That's right. It seems like
great.
time span for the development for drugs in the AD realm is very compressed, right? Compared to I think we grew up in our with biologics and seeing the progression of our currently 11 biologics being approved and introduced to the derm world, whereas AD, we're having lots of development and innovation in that area, and really in the much more compressed time period.
Which is actually brings up a good point. That's one of the main reasons we picked the Eczema Symposium for this conference too, because we felt like there's so much happening so fast.
Yes.
That the common dermatologist in private practice who might not be doing the trials in an academic center, it's almost kind of hard to keep up. So I'm hoping this weekend will actually fill a lot of knowledge gaps for all of us. Because the field is expanding. Because with psoriasis, you have like a couple of years to digest one set of information before another came out.
Right.
Whereas with atopic derm, things, which is a good thing, good problem to have, but a lot of information's coming out very quickly. So deciphering them and knowing which one to pick for which patient.
Absolutely.
It's happening quickly.
Yes, it really is. And I'm so happy that we're able to have this symposium here, and also, as a part of the centennial celebration of SF Derm, chaired by you currently. Yeah. So I think it's really, really exciting.
Yeah, exciting weekend.
Yes.
And for this podcast, we've been asking everyone, and we've actually kind of been mostly talking about this, but if you were to say just a few things, the future of dermatology, where you see it going, which is along the lines of everything we've kind of been talking about, but anything you'd like to add?
I think the future of dermatology is quite bright, and there are a few things I would say that we are seeing. Number one is just tremendous continued interest from medical students going into dermatology, and really seeing how residents who are coming out of residency really leading a bit more diverse path than, let's say, what the prior generations of dermatologists have been. And they're interested in not only sort of technical aspects of dermatology, but also very exciting aspects of entrepreneurship, and just, having a, better work-life mix in what they do. And I think that's something that's very exciting, and I think we're embracing as a field.
Yeah.
And also another area that we are seeing as a field, we're moving towards hopefully even a more diverse workforce, which I think will be very important for our patients, as well as our field in general. I think we continually face the challenges of making sure that physician reimbursement, for example, keeps up with the rate of inflation. So that's
tough. That's been tough.
Yes, that's been tough. And I think that both the AAD and as well as our advocacy arm have been really focusing on that as one of the key areas, along with, I would say, other field as well. But I think that conversation will continue to ensure that we're able to actually then provide the care to our patients.
It's true.
That they need.
Yeah, I saw a graph once with the rate of like physician salaries, and it's pretty stable, and then hospital administrator head of salaries, and it has just gone up so much since the 80s. So healthcare costs are rising, but the physician portion for some reason is not quite keeping up with, with that.
Yeah, and I think even just looking at inflation rates in general is going,
it's not keeping up.
It's not keeping up at all. So I think a greater advocacy from everyone is probably necessary.
Very, very important. And I would say in the Bay Area, actually, especially PAMF and our different sites, it's actually kind of hard to recruit newer docs because it is so expensive in these certain areas. So you feel it more than anywhere. That the pay really hasn't quite caught up with physicians being able to come out and get mortgages and paying off student debt. So it's a huge problem.
Yes. Yeah. So... But we have a lot of great minds in derm.
A lot of great minds. They'll figure it out. Lots of innovation.
Focus on that.
Sounds good. Well, thank you so much. Thank you so much for being here for the podcast and this weekend. And you'll be giving lots of good talks tomorrow.
Yeah, I'm very excited about. And I look forward to other speakers. The program looks fantastic.
Thank you so much again.
Yeah. Thank you for having me.